Good morning, Annalise, and thank you. And welcome everyone to the 2022 annual colloquium that is sponsored by the American Institute of Public Health Dentistry, or AIDPH. Thank you for joining us to discuss transforming veterans' oral health, illuminating equity and sustaining impact. Each year, AIDPH hosts a colloquium that explores the current scholarship in dental public health. This is an exciting time for AIDPH as we continue to expand while remaining evidence-based, relevant, and responsive. This colloquium is grounded in AIDPH's first Veterans White Paper, Veteran Oral Health, Expanding Access and Equity. There are profound and prolific oral health disparities across the US, and veterans face unique challenges accessing oral health care. As dental public health leaders, we have to identify, create, and implement solutions to address these oral health inequities. Colloquia such as this one promote public health scholarship to dental public health practitioners, academics, educators, advanced education students, dental public health residents, and advocates. Over the next 2 days, it is our goal that you gain a better understanding of the oral health disparities related to veterans' oral health and how to implement strategic solutions that support health equity in the oral health sphere. With guidance from expert speakers and through participant engagement, the colloquium strives to identify barriers to accessing adequate oral health care for our veteran population and to explore potential solutions. What will it take to increase access to care, eliminate barriers to achieving health, and to promote systems of inclusivity that result in optimal oral health? The journey to answering these questions will hopefully begin at the 2022 AIDPH Colloquium, and we thank you for contributing to this conversation. At this time, it is my great pleasure to welcome Dr. Maisha Minter-Jordan, the President and CEO of the CareQuest Institute for Oral Health. Please welcome Dr. Minter-Jordan to deliver a welcome on behalf of the CareQuest Institute.
Thank you so much, David. It is such a pleasure to be here with everyone this morning, albeit virtually. So good morning, everyone. My name again is Dr. Maisha Minter-Jordan, and I'm the proud President and CEO of the CareQuest Institute for Oral Health. And I'm thrilled to join in welcoming all of you to our colloquium this morning. As was said, we are in for an engaging 2 days filled with thoughtful discussion, expert points of view, and actionable insights about the ways in which we can improve veterans' oral health. For those of you who may not be familiar with CareQuest Institute, we are a national nonprofit organization committed to building an oral health system that is accessible, equitable, and integrated. To do that, we work with thought leaders, healthcare providers, patients, advocates, policymakers, educators, and other stakeholders, including many of you here today, to accelerate oral health care transformation. Strong partnerships make our work possible and get us closer to a future where every person can reach their full potential through optimal health. Partnerships like the one between CareQuest Institute and AIDPH to advance veterans' oral health. For far too many veterans, a patchwork system of care and coverage leaves essential oral health care out of reach, and the impact is significant. Veterans are more likely than non-veterans to experience higher rates of tooth decay, higher rates of gum disease, and an increased need for restorative dental care. In fact, nearly 8 million veterans report their oral health status as deficient. Yet, many veterans do not qualify for dental care through Veterans Affairs, and those who do have difficulty navigating the complex system of eligibility and care. According to the VA, out of the 9.2 million veterans enrolled in VA healthcare, only about 15% are eligible for comprehensive dental care, and only 33% of those veterans are accessing their benefits. But for many of us here today, this issue goes well beyond statistics. It impacts us and our families directly. As the daughter of a Vietnam War vet, I can speak very much to the issues that my father has encountered in navigating his healthcare as well as his oral health within the system. My father's experience in the military is not unique, but it is indicative of the larger challenges our veterans face. So for me, this issue is quite personal. In fact, I'm joined today by my colleague, Chelsea Chokas, who has been a key leader in our partnership and work with AIDPH and is herself a veteran. Chelsea, I'll turn it to you.
Thank you, Maisha, and good morning, everyone. As Maisha said, I'm Chelsea Chokas, and I'm the project coordinator for interprofessional and value-based care at CareQuest Institute for Oral Health. I'm also a third-generation Navy veteran and a military spouse. I've spent most of my life affiliated with the military. My dad served in the Navy until I was 15, so I grew up knowing the lifestyle and the sacrifices. And as I got older, I was drawn to serving a greater purpose, so I turned to what I knew and joined the Navy myself as a hospital foreman. And now I experience the military through a different lens as my husband serves. The military provided me with the hands-on medical experience and discipline to be successful in my education and career. It also allowed me to see firsthand the challenges veterans face when it comes to accessing oral health care. And I'm proud to be using my experiences to serve my community today. As Maisha said, this work is personal for me, and I'm thrilled to see so many fellow veterans and public health experts participating in this colloquium. Veterans experience a large oral disease burden, which is why an integrated and whole person approach is needed to prevent and manage oral disease in this population. Together, our work with AIDPH is shining a light on the social, structural, and individual drivers that impact veteran oral health. Our recent report includes strategic recommendations to increase accessibility to care for our veterans and stimulate rural oral health innovation. They include prioritizing trauma-informed approaches to clinical care, supporting minimally invasive and integrated oral health care, and fostering care team innovation. And all are informed by actual veterans and their experiences. Over the next 2 days, I hope you will engage fully with the many government, industry, and public health leaders joining us to explore these recommendations and others to ensure all veterans get the oral health care they deserve. I look forward to meeting and collaborating with you all over the next 2 days.
Thank you so much, Chelsea, and thank you for your service. Thank you for sharing your story and for your leadership on this important issue. I also want to take a moment to thank Annalise and the AIDPH team for bringing us together today and for spearheading efforts to better understand oral health needs within the veteran community. Without her leadership, we would not have such an incredible event in front of us. I hope we will all leverage this colloquium as a springboard to ask tough questions and develop powerful solutions to the oral health challenges facing our veterans. I'll turn it over to you, Annalise. Thank you so much.
Thank you. Hi, everyone. I'm Dr. Annalise Cothran, Executive Director of the American Institute of Dental Public Health. Thank you so much, Chelsea, Maisha, and David, for your kind words of welcome as we start transforming veteran oral health. Most importantly, thank you to each and every one of you for being here to signal your investment in oral health for veterans. Like my colleagues from CareQuest, this work is both professional and personal for each of us. As the wife of a Purple Heart veteran and a beneficiary of the military healthcare system, I have a sense of personal obligation to support the broader veteran community, understand their oral health needs, and amplify solutions that advance equitable care for veterans. For those who may be new to AIDPH, we are a 501c3 nonprofit focused on the science and education of oral health, pursuing our mission through the lens of oral health equity. We began our Veteran Oral Health Initiative near the beginning of 2021, focused on 3 key areas: access, research, and advocacy. Near the end of 2021, as has already been mentioned, we co-authored a forward-thinking white paper with CareQuest Institute defining 8 strategic recommendations for improving access to and quality of oral health care for veterans. These 8 strategic recommendations serve as the framework for this conference, planned jointly with our colleagues at CareQuest. I want to thank our partners at the American Dental Association, Delta Dental Foundation, Aspen Dental, and Patterson Dental for their support of this conference. These partners have not only invested in veteran oral health through this event today, but have initiatives within their own organizations supporting veteran dental care. We are truly honored to feature their work here and encourage attendees to learn more about their commitment to veteran oral health during the coffee break directly after this session. Throughout today and tomorrow, you'll hear more about our philanthropic partners at Fisher House Foundation and Minority Veterans of America. We're spotlighting their work each day, starting today with Fisher House Foundation. Fisher House Foundation builds comfort homes where military and veteran communities can stay free of charge while a loved one is in the hospital. We encourage you to visit their website and materials in their exhibitor booth during the coffee break and support their mission. Before I address the nuts and bolts of today's agenda, I want to give a special thanks to our team members who planned this event and will be supporting the sessions today. This has been a large undertaking, and we could not have implemented this conference without each team member's contribution. Today's agenda includes this plenary session, followed by a coffee break with our poster presenters and our conference sponsors, as well as a general attendee lounge. And they will feature the lounge and Who Below platform. So when you return from the coffee break, you'll then choose between 2 concurrent sessions, followed by another concurrent session. You'll have the AIDPH team members guiding you between breaks, and you'll navigate to sessions using the Who Below platform. Sessions will be in meeting format, as you can already see, and we encourage you to use the chat feature to interact with your fellow attendees throughout the day. A little bit of housekeeping before we start with our speakers. And number 1 is please keep video and audio off while speakers are presenting. So as I mentioned, this is a meeting format, and to give our speakers all of the attention, it would be helpful to keep both of those items muted. Continuing education credits are available throughout this event, and attendance is verified by codes provided at the end of the sessions. You'll need to keep those codes and use them in the evaluation and continuing education request that is provided at the very end of the conference. As you've already been notified, sessions will be recorded and will be made available after the conference via our YouTube channel. Lastly, we ask that you add your personal pronouns to your Zoom name, and you can do so easily by hovering over your box in Zoom, your video box in Zoom, pressing the top right corner button that has 3 dots, hitting rename and adding your pronouns. We want to make sure this is an inclusive environment for everyone. And now I am pleased to introduce our keynote speakers, Dr. Rena D'Souza and Dr. Renee Joskow. Dr. Rena D'Souza is the director of the National Institute of Dental and Craniofacial Research, National Institutes of Health. As the director of NIDCR, Dr. D'Souza oversees the Institute's annual budget of approximately $485 million, supporting basic, translational, and clinical research in areas of oral cancer, orofacial pain, tooth decay, periodontal disease, salivary gland dysfunction, and the craniofacial development and oral complications of systemic diseases. Dr. Renee Joskow recently joined NIH's NIDCR as Senior Advisor to the Director and Director Dental Public Health and Research Fellowship Program after a decade serving as HRSA's Chief Dental Officer. Dr. Joskow also serves as NIDCR's Acting Director of the Office of Science Policy and Analysis. She is a dentist and a medical epidemiologist, holding both a Doctor of Dental Surgery degree and Master of Public Health degree from Columbia University. Thank you both for being here. Welcome.
Thank you. Good morning. Dr. D'Souza, do you want to make some opening comments or shall I jump right in?
Jump right in. And if I can share my screen whilst you're doing that. Here we are.
So
yes.
Would you like to go first? Go
yes,
right ahead,
yes.
Please.
Thank you. Thank you, Renee. I bring many warm greetings to this very, very special group of listeners and organizers. Annalise Cotran and David Capelli, you all inspire me. And what Maisha and Chelsea says will resonate, I hope, so deeply with NIDCR's own mission, where integration, innovation, inspiration are all part of what we do. So I'm hoping in the next few minutes to just give you an overview of where we are today, with where we stand with our vision and our goals to accomplish, to actually make oral health available for all. That is a true vision that we're completely committed to accomplishing. And it might take a few years, but we will get there. So I want to bring to you greetings in this very unusual time when we have learned so much about the importance of human connections, the importance of staying nimble and able to flex so that we can respond to unforeseen circumstances for the betterment of our society, right? We realize that partnerships and teamwork matter, that innovation, ingenuity and integration actually are what I think are deeply rooted in our psyche, waiting to be tapped and explored, right? Shark Tank approaches actually do work, we know. However, we also learned that there were infrastructure and capacity needs that the emergency, like the pandemic, exposed to us. Mostly that health inequities and social determinants of care exist. The very same populations that succumbed to COVID early on in the pandemic, when mitigation was not as efficient as it could have been, right? The very same populations are those that today seek better access to healthcare and to oral healthcare. We've known that things that we kind of played with initially, like telehealth and telemedicine, now actually do work. And we have the technologies to back that up, which I hope will address the access to care issue that Dr. Caton mentioned, Chelsea mentioned. Science and technology and leadership matter. That we know, I think, in many, many ways. So thank you. Thank you, AIDPH, for holding your community together in this time, and to Annalise especially for really organizing this superbly. We had a very successful year. I was a virtual hire to NIDCR, so I've been virtual since. But I've had, it's been a wonderful year, great staff. And I must say, one of my pride accomplishments, I would say, was the hiring of the attracting Dr. Renee Josko to our team as a senior advisor with a wealth of expertise in the areas that would be highlighted in this meeting. So Renee and I will be sharing the podium, so to speak. I'll certainly go over the broad visions for NIDCR, give you a few more specifics, and Dr. Josko will follow with far more detail and depth from the report that has messages for this community. So obviously, it would help to actually take a step back and look at what this area of science and technology actually offer us. It's huge, and I'll spell that out further. That we do, for the first time, I think, in a very unprecedented era, have the opportunity to transform human lives in oral health. We actually do. What was distant and beyond our fingertips is now very much at our fingertips. I want to give you a view on how NIDCR is positioning with NIH to turn these discoveries into use-driven research where the patient is at the center, the patient's family and communities are at the center. I think public health research and care was very much kind of on the sidelines until the pandemic pointed out the importance of public health interventions. I'll give you a sense for where we stand with the pandemic research and how we plan for the next 25 years of success for NIDCR, where oral health for all will become a reality. So there used to be a time when, 30 years ago in academics, where the more you dissected the onion to get to the very basis of disease, you were rewarded. And that reductionist approach now no longer is it doesn't have as much meaning as coming together, just like Chelsea said, that the integration of all the various sciences where the patient is treated holistically is the way to go. And that is possible today. And this is a wonderful article that talks in the context of precision medicine, how these fields have actually converged. What's also important is the fact that we can treat a patient on an individual level for an individual lesion or a disease or a condition. We must look at the family level influences and the community level influences. And it's this kind of holistic approach that brings all of these attitudes and behaviors together so that we promote health from within. The patient takes charge, and we, as best as we can, understand the family and the community settings, because these upstream determinants of health that you know so much about actually do influence the progress of disease. So right now we have in our portfolio a very diverse range of sciences that cover every area based on disease, on which stage of the disease we want to intervene, what stage of life we care about, which is really from birth to grave, what kind of cross-cutting approaches we can use, a combination of, and the scientific disciplines of interest. And I've highlighted those that are particular, really are prioritized by NIDCR: data science, behavioral and social sciences, workforce development, implementation. So we take discoveries to the community and to chairside, to practitioners, and of course, the main issue of health disparities. So when the report was transferred to NIH and to NIDCR as a responsibility that we took on from the Surgeon General's office, it was daunting. It was a daunting task because there were 400 contributors, experts in the field who contributed, and they examined what we've done in the last 20 years, acknowledging that, in fact, science and technology has progressed dramatically with great discoveries in understanding dental, oral, and craniofacial tissues. But we also wanted to know, across the lifespan, has that been translated? So has what we know been translated to what we do? That was the driving question. So it is a living document. I invite you to read it. The executive summary is a short version of the 785 plus pages that are in the actual document. It's free, it's available, it's easily accessed. And the reason I want that ownership to be a shared model is that it has to be living in each one of your minds, your institutions, your groups, your organizations, so that we can this time make a difference and move the needle in a palpable way. So when you take a look and a step back, and Renee actually came up with this list, you'll see that over the 20 years, the demographics of this nation has dramatically changed. We've moved into a digital era of technologies. The way we deliver our services are being looked at seriously. What we deliver is considered. Disease trends are noted. And I'll tell you that HPV, for example, is a rising concern for us because it is turning out to be one of the more dominant cancers that are oropharyngeal, that are detected late and causing a lot of hardships to patients and their families. The diseases is like the unexpected, like COVID, SARS-CoV-2 brings its own set of challenges to our society. We've had amazing discoveries, but yet we persist with divides and barriers where the determinants of health are sometimes seeming beyond our control. And of course, that the deadly viral pandemic itself threatens our world, and as there may be more to come, right? So, but what we do need, and what NIDCR stands firm about, is a robust research enterprise, one that provides the evidence that will drive reforms and policy changes, that will reduce the negative impact of upstream determinants. We can eliminate them, they're part of our society, but we can try to mitigate their impact on health. That we need to reconfigure our oral health care delivery and workforce is one of the themes that the report emphasizes. That we, in fact, think about the oral health professional we wish to train for the future in this very integrated world that can be committed to treating all individuals and affording oral health for all. And of course, the bigger barrier rooted in our culture is the need to reduce or eliminate barriers, structural barriers that come from social, economic, and other systemic inequities. So the report itself, and I don't think this is completely current. I think there's more in terms of how many social media impressions and online outlets we've explored, and it's featured in Lancet and New England Journal Perspective articles. In fact, the New England Journal Perspective will be out in March, early March, on the 3rd to be exact. And it was co-authored by Surgeon General Murthy and Francis Collins and myself. We also choose to publish to targeted audiences interested in educational directives or gaps. JADA for the private sector and for legislation, the public health community to deal with the policy reform and actually collecting the data in real time to make available, and implementation sciences in a sense, and the JDR to focus on the research directions that are naturally going to evolve from this document in the shared ownership model. So please watch out for those. And of course, our outreach on various levels, and this is one example, along with the webinar that ADR held. It was the first in what I believe will be a series of webinars hosted by ADA, you're mentioned here, and ADEA. And of course, Santa Fe and other groups are involved. And the best part of this report experience for me was a celebration of our science. And now the challenge is, how do we take that science and reduce the burdens of dental and oral diseases? As a director, I am deeply committed to that impact. And you can see from this cover letter and just from what we've highlighted that commitment is real. It comes from the Office of the Surgeon General, from NIH, and of course from NIDCR. And if you can, it's the first few pages of both the executive summary and the report. You will see this statement. Now, whilst this was all going on, as a new director, I thought it was very important for me to engage our community, to bring us together, to unite us with a common sense of a common or shared vision. And we had our strategic plan, 3 main focus areas, and the strategic plan was released just a couple of weeks after the report was released. Also available online. It's not as long as the report. It's easy to skip through, and it really stresses the need for translation to make our research meaningful to populations in need and in health as well. We are very firm in developing a pipeline of future scholars that represent the demographics of our nation, and very importantly, to measure what we do. And I know you're going to do the same thing after this, to see how many listen and what is the follow-up. We're guided by core values, and that's important, and those are defined there. So our strategic plan is, as you will note here, places the patient in the center, and doesn't make the translation a linear bidirectional continuum, but rather a circular one where everything is needed for the whole, and the patient being the whole right here. So our first goal is to look at what is this business about oral health being connected to general health. What is the meat that we can put on those bones to make this a very credible association? Right now, we have associations between Alzheimer's disease and edentulosum, cardiovascular disease and periodontal disease, and you'll see many more such associations. Understanding the molecular basis for that will be important. We can take that information and translate it to a single individual by looking at their background and where they belong and their genetics and all the omics, and bring it together to come up with a very tailored, prescribed treatment for the right patient at the right time for the right reason. Then goal 3 is where we would be leaning on your society to actually really help move the translation into the community so that implementation science actually takes much firmer ground. Committed to training the future generations of a diverse group of oral health scientists. And then our partnerships with you and other stakeholder groups is so important, because we can't do this alone. None of us can do this alone. We just simply need to come together and show that teamwork. So what did we do during the pandemic? In addition to these issues, is to really drive the science, to make sure that our science was made available to the community. We funded and I think I have that. It'll come up. We funded studies that look at, from a global perspective, this is NIH, as to how we can explore therapeutics from repurposed drugs that were kind of set aside in a freezer, have been brought out now and are being tested in various combinations to see whether we can actually help a patient that has been infected with SARS-CoV-2. We're looking at ways to assess antibody levels and also T and B cell memory responses in reaction to the vaccine. And also more recently, there is some new data indicating that during pregnancy, there could be inflammatory responses that could affect the fetus. So that's an important thing. And here is a link so that you can get more areas explored. I think it was very nice to see that in addition to the testing, the many kits that were developed through NIH's innovation and partnerships with the community, that we were able to focus on therapeutics for the future, really, therapeutics that in fact would have a place in the treatment of cancer for the broader spectrum of diseases. And so these were the 5 focus areas that this initiative called ACTIVE was focused on. And you can see that they all really looking at our preparedness for the next pandemic, and that we, in fact, have a robust clinical trial workforce. We've looked here more specifically on identifying new variants and finding a platform that would allow us to very quickly test whether a variant is, in fact, a pathogenic one or one that is not likely to be infective or transmissible. So and you can see that unfold with the Omicron strains. And there's this platform that is, I think, going to add to the infrastructure for future pandemics. We've also got an infrastructure right now for looking and standardizing sequence data to understand the natural history of variants as they emerge in different parts of the world. What is very exciting is the fact, and this came from a lesson learned, that we realized that educating the community, science communication, was not as robust as we would have wished it to be. That it was important for us to develop partnerships with leaders from the community and from religious entities so that we have a readiness of people who understand the need to step up and to join team efforts when in fact we have a worldwide crisis like the pandemic. And I'm hoping that through SEAL, that NIDCR will connect with SEAL, because that infrastructure is already ready so that we can use our oral health betterment strategies through something that is available here that didn't exist before the pandemic. And you can see all the alliances here that are so important to get through. And just so that you know, there is a grant that is now housed, a huge effort that is housed as a hub at NYU with many other spokes around the country that is looking specifically at the long-term effects or impacts of COVID. And we all know that oral health is impacted. There's dry mouth, tongue ulcers, loss of taste persists, and obviously the secondary effects of bruxism and stress that are reflected in TMD dysfunctions. So this is a slide simply describes the initiatives that NIDCR funded, starting from very clinical to assess operatory conditions to very basic science approaches. And this is who we are. And it also showed that the work done by our intramural investigators pointing to the fact that SARS-CoV-2, the virus itself, could attach to oral mucosal cells and actually enter the salivary gland, divide prolifically, and be available such that salivary diagnostics would pick up viral sheds. So all of that was done over the last year. I'm very proud of this effort, along with the effort that the PBRN has put to look at safety conditions and the use of mobile dentistry and telemedicine approaches. Now, when you step away from the pandemic itself, a business continued as usual, really, for NIH. We have a variety of trans NIH programs, and that is so important because, like you both mentioned, that integration of connecting beyond the oral cavity, knowing how others are dealing with pain and neurosciences can help us better understand that. And I know that's a very key issue for veterans, dealing with that pain and also the post-traumatic stress that one inherits from service. So from cancer to very innovative techniques in imaging. We have, and our DCR has a role in each one of that. We collaborate, we bring people from the outside. We'd like more to come into our fields, and we're trying our very best to advance. An example of that is TMD. That area of research, as you know, has been approached in a very singular fashion. So one lab wasn't working on one thing versus another lab, with the tremendous commitment from Terry Cowley and her foundation. It has drawn attention in Congress that this is actually a public health issue. And we take that seriously, responded to the calls and to the recommendations from the academies to come up with an idea of drawing people in who would look at things from a reductionist approach as well as from a holistic approach, and putting it all back together to really understand the progress of the disease, the pathogenesis, and the best therapeutics or the best points of intervention. So please keep an eye out. Do get involved in it. There's no one that should feel excluded from any of these efforts. We have right now the concern that HPV positive oropharyngeal cancers, mostly associated with tobacco and alcohol use. That's for all oral cancers. But this particular one is back there in the oropharynx, hard to detect, rising to a proportion that is even higher than cervical cancer. Yet the environment is quite different from cervical cancer. So we are making a concerted effort to understand the condition, to move it forward, especially with the identification of biomarkers that will tell us early on that something is wrong, along with the technologies of laser detection, et cetera, that will help us really help with these patients. There is no doubt that the field of data science and big science is taking root in our society. And NIDCR is very serious. We're likely to have our own Office of Data Science and Management that will look into ways in which we can integrate from various databases and repositories, play a role in integrating health records. So long in the works, time that we actually came up with something that we as a health community can share. So we understand the patient's whole holistic being. And you can see here, we do have an NIH data sharing policy, and we will be looking at this strategic plan in a very fair and honest way by protecting the patient, protecting societies and communities, but yet using the data to the advantage, especially in identifying health disparities that exist in communities that are underserved and underprivileged. I don't have to say more to you than the fact that the events of the last year were so disturbing with George Floyd's murder, actually. It brought to light the very many flaws in NIH's own thinking and its processes and its procedures. This is this reason that Francis Collins issued a public apology. Now, for us in the oral health field, our problems are more difficult and challenging because our pipelines into dental schools are narrow to begin with. So we're thinking of diversifying the biomedical research and public health research workforce for oral health. We have to use a team approach. You can see from this data as to where we stand. This was published in our strategic plan, so you can look at it in more depth. And you can see that we have very low percentages of representation by race and ethnic backgrounds in each of our funding areas. So to the far left is the young, early starter who's either getting a PhD or right out of a PhD. The career development grant are the funds available to tide them over to the faculty position. And then you move into the independent stage. And you can see that every level, we're doing better with women in some, but in general, our race and ethnic distributions are not good and resemble what NIH actually has too. So we cannot solve these problems with the same thinking we used when we created them. How wise was that? And for that reason, we're creating a public-private partnership with corporations, with associations like yours, with government, legislators, deans of dental schools, and of course, our own grantees and our council members to come together so that we can together solve the problem. I don't think NIDCR or any one association could do that. Now, what's happened in the meantime, and I don't know if I mentioned this before, is this element that we would approach our research, not just public health research, but look at all our diseases in the context of the individual, of family, which if you're looking at a genetic disorder would mean the genetics, and also the impact of what help someone has, what is the influence of communities on this. And because, not just because of the pandemic lessons alone, but because when I came onto the directorship, it seemed very important for us to be training in the dental public health arena a cadre of researchers whose focus would be creating the science that moves the needle and guides the policies. We relaunched the 3-year program, and I'm very pleased to say that Renee, with all her experiences, Renee Joskow is leading that, shepherding it through now its first year that will begin in June or July. And we'll have a 1-year curriculum, which would be very dental public health focused. For those who come in with MPHs, that's a great orientation that qualifies someone for certification, board certification, right? And licensure. But that will be followed with a 2-year, very focused postdoc experience on our campus with mind-boggling, boundless opportunities to focus on. But these individuals could also work with HRSA and CDC and FDA on different issues that require such collaboration. And we have right now 2 very highly qualified applicants. I ask you to take that message to your mentees who want that focus in their career, because we really do need that pipeline. I'm hoping, David, that this would serve in a way, if we model it correctly, that it would serve as an example of how other public health programs around our country in dental schools can be thinking about the future. We also have a clinical research fellowship where you can come in with a DDS and or PhD, DDS PhDs preferably, and you get very housed into a clinical research methodology. You can learn that in the setting of Building 10, which is the mecca for us at NIH. It's the place where all the clinical trials research is happening. And you learn here basically how to position yourself for very successful academic positions in patient-oriented research. So I want to end here with a lot of hope, because it is the best of times. I'm going to look at all the good stuff. It is the age of wisdom. We do believe, and we see a season of light. And spring is really actually in the air, bringing with it hope and promise for the future. So this is my favorite Charles Dickens quote. And with that, I want to transition to Renee, who will talk about the problems that the report address and the plan that we have. So Renee, all yours. Thank you. I hope I didn't go over time.
Thank you, Dr. D'Souza, Rena. What a wonderful, motivating discussion of the work. At this time, the meeting organizers just brought to my attention that we actually only have a few minutes left for this session. So I think it best, given the scope and the breadth and the exciting things that you presented, perhaps we can open it up to questions from the field for you, if that's okay, Dr. D'Souza.
I would welcome that. Thank you.
So if folks want to just put questions in the chat, or if you prefer to just unmute, if that's possible, you can just ask your question directly. I'm happy to moderate. And while you're thinking of your questions, we are trying to find another time, either during one of the coffee break sessions, where I can present the information from the Oral Health in America report on veterans and on military oral health. So we're trying to find another place where we would be able to share that with you.
Thank you. And if anyone has questions about grants and how NIDCR functions, if you're thinking of an idea, and I see my friend Rick Balakovic here leading a very special initiative in NYU, if you have questions, we are a public service organization, so we depend on that input because we take your ideas, make it a concept, vet it through our system, and then it becomes a grant opportunity in an area that was not funded before. So for that reason, please do stay in touch with me or with Dr. Jusko.
Thanks. Well, I see a question from Dr. Scarlett. The question is, where is the intersection of the plan with veterans' oral health? How can Cerner and Dentrix be better integrated in medical records at the VA? How are veterans' voices being included as partners? Dr. D'Souza, I don't know if you have a specific answer for that. I might be able to share some insights.
Oh, absolutely. Please do that, Renee.
So, Dr. Scarlett, thank you for that question. Later in this symposium or this colloquium, I understand that Dr. Scott Trapp, who represents the VA, will be speaking. But I can tell you, even from my presentation and my personal experience, there is currently underway a integration, upgrade, and modernization of all of the Department of Defense electronic health records with the veterans' health records. I remembered, I actually double-checked the date, and I do remember that in 2003, the Department of Defense decided to take on a new system that's called ALTA, rather than incorporate or rather than integrate the current system that the VA was using. But the purpose of this modernization effort is so that veterans and active duty members, as they transition to veterans, will be able to have a single health record that would electronically be able to move with them from their active duty status into veteran status and be able to be used in the VA. I do see that your question and I believe I understand that your question is, how are veterans' voices being included in the plans? And I would say, if you can hold that question would certainly be better answered by Dr. Scott Trapp a little bit later. But I hope that answers a portion of it related to the infrastructure and the systems itself.
Yes. And I can just add one little tidbit, Margaret, which is that the intersection of mental health, of substance misuse, and of oral health is an extremely important intersection. I see it as a Venn diagram with oral health kind of in the middle, or the oral health practitioner in the middle, are deeply connected to veterans' issues, right? Amongst other things. And so I think that will be brought to attention in a special article that will be written as an offshoot from the report by Judith Albino and Christian Stoller from Columbia. Yeah, so watch out for that.
I'll also just share, and as I said, I hope we get to do the session that I had queued up at another point in the colloquium. But there are also examples of areas in the report itself that talk about, for example, the Heroes Clinic in Denver, Colorado, where care is being provided at a local level for veterans. There's certainly significant services provided for veterans through the FQHCs, the Federally Qualified Health Centers, as well as HRSA's Health Center program itself. But in terms of, what the outreach is of the VA or the VHA specifically to these groups that you mentioned, again, I think that Scott would be happy to answer that question. So the example that I gave you is a partnership actually between the University of Colorado School of Dental Medicine and Delta Dental. Any other questions? Dr. D'Souza, can you speak to what your thought process or your priority, because I've heard this directly from you, but your understanding the importance and the priority of dental public health as part of, let's say, the triad or the different expertise that you've brought into the Institute. Can you speak a little bit about your thought processes and why you've restarted the dental public health residency and how you see that either related to social determinants of health or really the specific expertise that dental public health specialists or those in the field of dental public health bring?
Oh, that's a great question, Renee. Thank you. It was a combination of the pandemic and my own exposure as an academic when I served on the external board of review board for the Northwest Alaskan Disparities Grant that was headed by Peter Milgram at the University of Washington, Seattle. And I got this deep understanding just purely organically by listening into sessions where they were attempting to use xylitol as a preventive in very rural populations in the Northwest Alaskan region. And one of the theories was that if they would give xylitol to the women figureheads in families, it would help. Because what was customary was for women, it was either the mom or the maternal grandmother or the aunt or sometimes the sister who would chew the food within their mouths and then make it soft and easy to digest and transfer it literally to the baby, the infant. Now, most of these adults did have raging periodontal disease or caries, and there was a transmission of that. But as what I understood was that you just don't go in without a behavioral or a conditioning and an understanding of the cultural behaviors that guide the societies, right? So that was not received very well. It wasn't that the grant failed in general, but that particular approach did not succeed because we did not have that understanding of the community setting. And it made me appreciate public health in ways that I hadn't before, because I was, developmental biologist, a geneticist, very reductionist. What makes this important at this time is that you know where the gaps are, guys. We know where the gaps are. You can't tell me at any given time how many individuals in our country are still receiving amalgam restorations or what other composites are being used and what their success rate is. From a national perspective, we don't have our finger on the pulse. It doesn't have to be real time as of today, but at least let's go back a year or two. We don't have that data. So data collection, integrated records, looking at clues that we get about disease trends in populations is so important for our mission, which is to make sure that oral health is not a privilege, that it is a right, and it belongs at the table with the other health professions, right? The other thing, Renee, that I want to stress is that the oral cavity, when we think about the oral systemic connections, there's more to it than meets the eye, right? Because what do we put in our mouth? The mouth is a portal to the rest of the body. And the risk factors that caries and periodontal disease have are exactly the same as what predisposes to cardiovascular disease and diabetes and some other diseases. Everything goes through the mouth. Bad nutrition, alcohol, tobacco, just name it. So how should we assume responsibility for that entryway into the body if we didn't have a robust, sustainable, energized workforce in dental public health? The communication, the implementation sciences, all of that comes into play, I think. I hope.
Yeah, no, that's wonderful. That's certainly speaking our public health language. And I think everybody in the audience probably has a really big smile on their face right now. I think we're at time because I understand they have some sponsor recognition or some transition to breakout groups. So Annalise, back to you.
I'm so sorry if I bumped you off, Renee. That was not the intention. I thought I had 30 minutes. It probably went over. But will you have a chance to present your details? Will she, Annalise?
We're going to try to work it out somehow.
Okay. Forgive me.
Thank you both so much. We are so honored to have you both present and discuss things during this keynote session. And we certainly appreciate the support of NIDCR and veteran oral health care. We know that this remains a priority on all levels, including the federal level. And so we're very thankful to have your support and sharing your words here today to kick off our colloquium.
Thank you.
I also want to provide the CEU code for everyone before we transition. And so that is OHA 215VET, OHA 215 VET. So remember, please keep your CEU codes, put it into the evaluation at the very end of the conference. So you'll receive that at the end of day 2, and you'll have an opportunity to verify CEUs at that time. And so moving into the coffee session, which you will participate in on the Hubelo app through the lounges in the Hubelo platform, we want to provide a highlight for our philanthropic partner today, Fisher House. Reading a little bit from Fisher House, this year we are honored to support the Fisher House Foundation and its efforts to provide comfortable and free housing for military and veteran families while their loved ones receive treatment in the hospital. Since the early 90s, Fisher House has saved over 413,000 wounded veterans and their families $500 million in out-of-pocket services for lodging and transportation. While many wonderful and worthwhile veteran and military-focused charitable organizations are available to support, we feel a particularly strong connection with Fisher House. Whether healthcare or dental care, we believe our veterans and their family members deserve the absolute best, and we are proud to work tirelessly alongside organizations like Fisher House Foundation to meet those needs. We encourage you to visit the lounge for our philanthropic partners. If you would like to say your thanks to Fisher House Foundation, learn more about them, support their mission, again, you can do that during the coffee session in the Hubelo app. We also have a lounge available for our poster presenters, and we are very excited to have 3 posters available in the lounge. And our poster session is supported by the American Dental Association. We also have a lounge open and available for all of our partners, including the ADA, Patterson Dental, Aspen Dental, and Aspen Dental and Delta Foundation. Thank you. I skipped ahead on my notes. We're very excited to be able to learn more about what each one of those organizations are participating in and their philanthropic and organizational endeavors too. And so before we close out today, I'd like to turn it over to Dr. Shaylee Gupta on behalf of the American Dental Association to welcome us into the poster sessions.
Yes, good afternoon, everyone. I'm thrilled and honored to be attending the AIDPH 2022 colloquium, Transforming Veterans Oral Health Care. My name is Shaylee Gupta, and I'm the chair of the American Dental Association's Council on Advocacy for Access and Prevention. And the American Dental Association is very proud to collaborate with AIDPH and other organizations on this very relevant and important topic that we are all concerned with, which is the oral health care needs of veterans and lack of access to care. The ADA is committed to ensuring that veterans have access to oral health care. ADA policy supports authorization of resources within VA medical centers and also supports the work of component and constituent dental associations and dental organizations to develop new programs with outreach strategies to assist unmet dental needs and finding dental homes for veterans. And the ADA also advocates these policies on the Hill in DC. And I think we all know by improving the oral health care of veterans in need will improve their overall health and their physical health and their mental health. So thank you all very much and enjoy the poster presentation session.
Thank you so much, Dr. Gupta. And so now we invite you all to navigate back over to the Hubelo app, join a lounge, take a seat in the lounge, and interact with all of our attendees over there. Thank you.